Good evening, everybody. I bring greetings from India. I would like to thank the Egyptian Orthopedic Association, Benha Orthopedic Department, and Professor El Ashab in particular for the invite to present in this wonderful meeting. We're in the middle of some challenging times. My thoughts with all those who suffered and tributes to those serving during this deadly pandemic. I thought I will present an interesting case today. We have published this case recently. It's on a terrible triad of the posteromedial knee associated with ACL injury. Sorry. This is the case that we published. It's this year's JCOT. It's about a bony injury with ramp lesion and a double meniscal injury, defunctioning the meniscus and forming a terrible triad in the knee. ACL is the most commonly injured ligament in the knee joint, and it is associated with meniscal injuries in 47 to 61% of the cases, and a ramp lesion in 9 to 17% of the cases seen during ACL reconstructions. Other ligaments may be injured. There may be bone and chondral injuries associated along with this injury. This case is a 24-year-old man who presented with instability of the right knee of 2 years duration. A 10-foot statue of Lord Ganesha, who is a popular Hindu god, fell on his knee and he sustained this injury. He is a fit and well person, and on examination of his knee, there was no effusion. Lachman was 1+, anterior drawer was 2+, pivot shift was 1+, PCL, PLC, collaterals, and meniscal signs were negatives. Range of movement was full without pain. Radiographs showed early osteoarthritic changes in the medial compartment with reduced joint space and osteophytes. There is a hint of bony injury of the tibial rim posteriorly. MRI scan confirmed the fracture of the posterior rim of the medial tibial plateau as seen in the sagittal sections, as well as there is some evidence of injury to the adjacent meniscus. In our case, the following were seen. There's a fracture of the posterior rim of the medial tibial plateau. There was a ramp lesion. There was double injury to the meniscus. The posterior medial meniscus root was avulsed. There was radial tear of the junction of the posterior horn and the body, leading to an amputation of the posterior horn of the meniscus, and that has displaced, along with the rim fracture fragments, into the ramp lesion. An arthroscopy was done, and these were the findings of arthroscopy. There was no ACL there. This was a posterior, the trans-notch view showing the posteromedial compartment. This is the medial compartment. We can see that posteriorly there's no meniscus. Again, a trans-notch view. This view is through the posteromedial portal. You can see there's a fracture of the posterior rim of the proximal tibia, along with the ramp lesion. This is again a medial compartment. You can see the posterior part of the meniscus is missing. And there is osteoarthritic changes, early EOA changes within the compartment, some fibrillation. Through a posteromedial portal, the ramp was explored. We can see there's a tissue within the ramp, which looks like possible meniscus and osteochondral fragments. They're all adherent, and the morphology has changed. It was difficult to remove every piece of that, so whatever we could remove, we removed. We made another second portal into the posteromedial compartment in order to one to hold, the other one to remove the fragments. So using a first pass device, a fiber wire was passed through the capsule, synovial capsule, forming the ramp. Another bite was taken. And taken out through the posteromedial portal. A guide was placed to pass a guide wire coming from anterior into the posteromedial compartment where the fracture was. Over the guide wire, a tunnel was drilled using a 4 millimeter drill. The shuttle suture loop was passed through the tunnel to take the fiber wire anteriorly. So the fiber wire was taken through the tunnel anteriorly. And when we pulled from anterior, the ramp was closing up. This is a view from the posteromedial portal. We can see the ramp closing up. And we pulled on the fiber wire anterior from the anterior aspect. The meniscus was debrided, the fracture surface was debrided, and the ramp lesion closed. This is a postoperative radiograph. ACL reconstruction was done. This suture disc was holding the fiber wire from the posterior aspect, holding the capsulosynovial junction to the stitched and held to the posterior fractured surface. Ramp lesions have been classified as stable or unstable. A more anatomical classification was done by Tonert et al. The mechanism is unclear in the current literature, and treatment is to fix the unstable type of ramp lesions. Risk factors for ramp are bone marrow edema, contact injury mechanism, and concurrent lateral meniscal tear. Some other factors by Sonnery Quartet were male, age less than 30 years, revision ACL reconstruction, when side-to-side laxity is more than 6 millimeters, and in chronic ACL ruptures. Meniscal root avulsions, what we saw here was the posterior horn of the posterior root of the medial meniscus was avulsed. It belongs to type 5 of classification of root tears according to Laprade et al. In the meniscal body tears, the tear we saw is a radial tear at the junction of the body and the posterior horn. Normally they occur as a longitudinal tear with or without bucket handling. There was complete amputation in our case and segmental loss of the meniscus, which has not been reported before. Although bone marrow edema of posterior tibial rim has been reported in association with ramp lesions before, there was no report of fracture of the rim in association with meniscal injury and ramp lesions. So our case has implications on classifications of ramp, meniscal root, and meniscal tear types. It adds a new dimension to these injuries, tying all these injuries together. It extends severity of injury of these structures to a new level, leading to early onset of osteoarthritis. The probable forces involved are a posterior and inferior force from the femur on an anteriorly displaced tibia after the ACL is ruptured. It raises a lot of questions in managing such injuries. Multiple challenges are posed in the chronic setting, acute setting, managing meniscal loss with deficient base, repairing ramp to the bone, the role of partial meniscal allograft transplantation, and how we identify and prepare such injuries preoperatively. This case raises more questions than answers. We are not sure how much of a stable base is required for a functioning meniscus before we could consider partial meniscal transplantation. It is an interesting case for discussion for which I don't have all the answers. I would welcome inputs from esteemed faculty and audience on how to go about managing this case and similar cases in the future. Thank you very much. Take care and stay safe.